like to thank Mark McGurk and Jerry Kearns for putting this program together, particularly on this area of saliva gland, which is of great interest to us all. This is a very interesting group of people, ENT, who we all work with very closely, and Max Fax, and it's talking about salivary gland disease, which really is about the one area that crosses all parts of our maxillofacial surgery specialty. So with no further ado, I'd like to welcome Professor Oded Nahlieli, Chairman of the Department of Oral and Maxillofacial Surgery from Israel, to talk about the surgical management of parotid stones. Thank you very much.
Thank you very much. And this is my center from Barzilai Medical Center from Ashkelon, and I will present my experience over the last 20 years with surgical management of parotid stones. Till a few years ago, the only option for parotid litíasis was if the calculi is till the curvature of the Stenson duct, intraoral removal. Posterior to this region, superficial parotidectomy approach was the only option. But nowadays, I am proud that we can perform most of the parotid stone with minimal invasive technique, part with pure endoscopic technique, part with extracorporal shockwaves, lithotripsy, and part with endoscopic assisted techniques. According to Ewe and Zenk, the location of stones, about 64% in the distal Stenson duct, 13% in the hilum, and about 23% in the secondary duct or within the parenchyma. We divide it according to the third law, the anterior third, middle third, posterior third, and also the posterior third. We include the secondary ducts and stones within the parenchyma. The major factors affecting the sialototomy procedure are the location, anterior, middle, or posterior, the stone diameter, and mobile versus fixed stones. Other factors are duct diameter and stone configuration. The location is the most important factor. Diameter and mobilization will dictate the surgical technique. And I will present today the imaging before the endoscopy, the instrumentation, how to introduce the sialoendoscope, endoscopic sialototomy techniques, endoscopic assisted sialototomy, external lithotripsy combined with other techniques, and combined treatment for advanced sialotocases, and of course, our experience. The imaging. There are a lot of techniques that we can use, but I like the Combi CT. It's a very easy procedure, and you can combine it also with sialogram. And this is the view that you can get about 360-degree location of the stone with sialogram. And you can use it. This is for Sjogren, for CRP. And the future is the virtual endoscopy, and this is a case of Sjogren, and this is a tour inside the gland, and it's the exact technique as for the cardiac surgery. The instrumentation, we had to develop instrument according to the article by Zenk and Hero. According to the diameter of the duct, the diameter is about 1.5 millimeter. And the new development is a modular system that we have a reusable optical system, 0.9 millimeter and 10,000 pixels, and disposable sleeve. And what is most important, 120-degree lens. And this is a typical endoscope. This is a reusable part. And the new development is a telescope with a modular system that you can just change the handle, and this is disposable sleeves. And we can add basket, mini forceps, grasper, high pressure balloon, micro drills, micro needles, and micro brush. As you can see here, balloons, forceps, drills, etc. And now to the endoscopic cellulotomy technique. This was one of the main problems that we face when we begin our project of salivary gland endoscopy. So basically, we have two options. First of all, intraductal approach, and this is a pure endoscopic approach, and extraductal approach, and this is endoscopic assisted technique. So basically, we have the option in the anterior third to perform, this is a surgical plus serial endoscopy for exploration. And in the middle and the posterior third, we use serial endoscopy or endoscopic assisted technique in the conjunction with external low energy lithotripsy that I will show you. The intraductal approach, as I mentioned, is a pure endoscopy, and we can perform this technique if this stone is smaller than 5 millimeter, and if we have a patent duct. And for pure endoscopy, we like to remove the stone in one piece. As you can see, this is the first basket that we use. This we borrow from our urological friend. Nowadays we have a special basket, and this is just a nice short video clip that you can see how we can remove this stone with a basket. With the basket is a problem that you need to bypass the stone, otherwise it's, you can get stuck inside the gland with a basket. And we need to bypass the stone, as you can see here. And remove the stone. I like this kind of technique, the forceps, and with the forceps, it's a versatile technique. You can hold the stone from the frontal region. We don't need to bypass the stone. You can use it also for resection of tissue. As you can see here, the stone is inside soft tissue in the hilum region, so you can hold the stone, you can resect the tissue and remove the stone. And what is most important in parotid surgery, the parotid duct and papilla are very sensitive to trauma. And this is the reason we need, after every surgical procedure, to insert a stent. And this is a stent that we use. Now to endoscopic assisted technique, we have basically two options. One option is the intraoral approach, and the other is the extraoral approach. And the intraoral approach, first we use this technique for salivary glands, for submandibular glands, and we publish it, the ductal stretching technique. Nowadays, we can use it in the anterior third of the stentor duct, but as I mentioned, we have to use, after the procedure, stents and also steroids. And this is the technique. This is it in the anterior part, exploration and removal of the stone, and stent insertion and injection of hydrocortisone. The extraductal approach is for stones that we can't use the intraductal approach, and basically we have a few options. First of all, to identify the stone with endoscope or with ultrasound, and then extraoral cellulotomy with rhytodectomy or cheek approach. And this is the technique. As you can see, we have the monitor, we insert the endoscope, and this is via rhytodectomy approach, as you can see here. The cheek approach, as you can see here, in this patient, and I will show a short video clip. If it's aesthetically feasible, we use the endoscope, we mark the stone, and with the dissection, we identify the stone. And this is the stone. Removal of the stone, stent insertion, very important, and closure of the duct. Stent in the CT and the final result. If we don't have a patent duct, we can use ultrasound and biopsy guide, as you can see here. With a biopsy guide, we can remove the stone. And this is the stone. And we publish it in the international journal, and also Zenk and Euro publish it. And now to extracorporeal shockwave lithotripsy. Extracorporeal lithotripsy began in 1988 by Euro and Katz. In 2003, we successfully developed a miniature low energy and large focal zone lithotripter, and this is the machine. And here you can see we introduce the endoscope inside, and you can see how it disconnects the stone from the surrounding tissue. Don't try it, because it will break your endoscope. It will disconnect the lens from the endoscope. It's not painful. You can use it on children because it's low energy. And we use it as an adjuvant technique. We use it low levels of energy, 0.09 millijoule millimeter square. And we have two mechanisms: detachment of the connection of the stone to the ductal wall, and revascularization of the glandular tissue. And this is well known in cardiology. And as you can see, a new non-invasive cardiac angiogenesis therapy was developed recently, which couples the ability of low-intensity shockwaves to introduce angiogenesis. So basically, what we use it's for detachment of the stone from surrounding tissue, revascularization effect. And when we learned it, we combined it with advanced cellulosis cases. We combined this treatment, extracorporeal shockwaves, with pure endoscopy with endoscopic assisted technique. And our definition for advanced cases in the parotid is every stone in the middle or posterior part. So every stone in the middle, posterior or posterior third, we use first external low energy lithotripsy and then silent endoscopy or endoscopic assisted technique. We use external lithotripsy with low energy, 10,000 shockwaves per session, 3 sessions for every patient. And few case presentation. This stone before treatment, after 3 sessions. And in this case, this patient was sent to us after a failed attempt to remove the stone by endoscopic surgery. And this is after the first session, second session, and after the third session, the stone located very near to the orifice. This case, the stone located in the hilum, and after a C-section in the middle part, and with very easy endoscopy, you remove the stone. In this case, obstructed duct. It's a very difficult case. No duct, 2 stones, a big one in the hilum and one in the middle part. And the first stone, we use ultrasound and biopsy marker to locate the big part of the stone. As you can see here, we remove the stone. The second stone with the endoscope is a transillumination effect, as you can see here. And we remove 2 stones from the anterior part of the duct. And this is the result. Another case, a stone in intraparenchymal. So first of all, we use the endoscope to locate if it's intraductal or extraductal via radiotodectomy approach. So we can see, we try to search for the stone intraductally, but as you can see, it was in the parenchymal region. So now we remove the stones, multiple stones. And here we used the extracorporeal lithotripter to disconnect the stones from the surrounding tissue. Another stone. And the result, the multiple stones. This is a very nice case. After I had a lot of experience with humans, they called me one day to the veterinary hospital to treat a horse with a stone in his parotid gland. You can see a leakage of saliva, and they told me that it was a $1 million horse, and they told me that I have a lot of experience with humans, so I can treat this horse. So we did the same combination, the lithotripsy, and we removed successfully the stone from this patient. And now to our experience. We, till 2012, we had our technique on 3,062 glands. And from 2009 till 2012, we collect the patient that we perform the same technique, as I mentioned, with a low power lithotripsy. So we had 33 in the anterior part, 47 in the middle part, and 46 in the posterior, and also in the secondary duct. So basically, in the anterior part, as I mentioned, 33 cases. So 73% we remove, it was a very simple removal, and 17%, 9 patient intraductal endoscopy was needed. 100% after 12 months follow-up were free from stones and from symptoms. In the middle part of the stones, of the parotid stones, 47 patients. Stone elimination, total elimination by lithotripsy alone was in 18%, basically in small stones. 52%, 33 patients, we use intraductal endoscopy technique. 11%, 7 patients, removal of the stone with endoscopic assisted extraductal approach. 2% we had strictures, it was 1 patient, and in 12 months follow-up, 100% free from stones and from symptoms. In the posterior part, 22% we had total elimination of the stone by lithotripsy alone. 28%, 13 patient intraductal approach was needed. 15% in the posterior stones, 23 patient, we remove the stones with endoscopic assisted technique, and 2% failure, we had to use a superficial parotidectomy due to failure of this technique, and 1 patient strictures. So failure 2%, complication 2% of the patient belonging to the middle and posterior groups developed ductal strictures, but we successfully managed this group with endoscopic dilatation. And we publish it in the BAOMS and also in the otolaryngologic clinics of North America. The only contraindication for cyanidoscopy is acute cellulitis. And to summarize this lecture, parotid gland endoscopic surgical approach and external lithotripsy are true minimal invasive procedures. They are efficient and safe procedures. And in the future, superficial parotidectomy approach should be reserved only for cyanidoscopy failures and for parotid tumor surgery. And just to show you that we took this microendoscopy technique, and I will show you the connection between parotid and unbelievable implants. So we can use the same technique, the same endoscope, for endoscopic sinus lift, as you can see here. Instead of removing stones with the mini forceps, we can insert bony substitute inside the sinus, as you can see here. And this is the results. We can observe the nerve with the endoscope. The bone reacts like a soft tissue, and as you can see here, we can see immediately, we can see the nerve. Here you can see the pulsating artery near the nerve. And in the future developments, in the future, we'll have 3D image. As you can see here, this is the first 3D image of a parotid duct. So it will give us a better option to view and to navigate inside the ductal system, and digital endoscopy for a better picture. And thank you very much for your attention.
Thank you very much, Professor Nahlieli, for sharing your experience, which is vast. A few questions I want to ask you before I open to the audience. One is, we like horses in Ireland, so how did the horse do? The second question is, you use the stent, and you didn't really talk about the length of time you leave it in. And the third thing is, you talked about a parotid, where there was ductal obstruction, and yet you still went in and removed the stone, and I'd like to know what you did about the duct.
Okay. First of all, we leave this, it's not a stent, it's temporary stent. We leave it for between 2 weeks to 1 month. It's very easy to remove it. It's, the stent is with flaps and basket just that it will hold inside the gland. But between 2 weeks to 1 month, we remove. The strictures that after following the stone, we just dilate it with high pressure balloon. It's not it's not the lecture. We'll have another lecture regarding the use of other techniques in dilating ducts. But what we did is very simple. We introduced a high pressure balloon and we dilate it.
Good. And was the operation on the horse successful?
Oh, yes.
Good.
Yes, very successful.
Right. Any other questions from the floor? Yes, go ahead, yes.
I can't hear you.
Sorry. What do you do with stones that are adherent to the duct wall, is my first question. And the second question is, experience with pediatric patients I find quite difficult because the scopes are not small enough.
Pediatric patient, it's very rare. Pediatric patient, it's very rare to find stones in pediatric population. I think in all my career, I think I saw two kids with stones in the parotid gland. Most of the, if you ask about parotid, they have juvenile parotitis, juvenile recurrent parotitis. Stones in children, it's between 3 to 5% of the stone population, and it's mostly in the submandibular gland. Regarding stents, it's from polyurethane, so it's very easy to remove the stents. It's not adherent to the...
Sorry, no, I was asking about stones that are stuck to the duct wall. So when you put your scope in, it's stuck.
Stones. First of all, as I mentioned, we try to use low-power lithotripter. So the low-power lithotripter disconnects the stone from the tissue itself, because it's very difficult to remove. It's very difficult to remove stones that are adherent to the tissue. So first we try to do it with lithotripter, low power, to disconnect. We use pure endoscopy, but if you can't use pure endoscopy to remove it, especially with submandibular, we use the extraductal approach.
Any other questions? Now, if none of you have any questions, I'll have to ask some more, and they're very boring. I think your experience is absolutely vast, and you've taken what you're doing to greater limits. And I have to say, I'm not sure, and it's totally different to what we were talking about. You were looking at the inferior alveolar nerve.
Yes.
I presume you're looking down
Above,
the hole
yeah.
that somebody has drilled.
Yes, we use. It was not the aim of the lecture, but what we use it's after the first drill, the pilot drill.
Yeah.
According to the city, we have the option to view the anatomy from If it is D3, D4, till 4 millimeter in advance. So use the pilot drill, and then in 3 to 4 millimeter in advance, you can see the nerve.
See the nerve. We try not to see the nerve. But it's a good idea. And I just want to ask one other question on you opened up the ducts and you stitched the ducts.
Yes.
One of the things that in Max Fax we tend to teach, if we do a parotid stone and you open it, we would have opened it up through a superficial parotidectomy incision, dissected down to it. We wouldn't actually tend to stitch the duct because of the risk of stenosis by putting stitches in.
No, we use nylon 560 stitch.
Yeah.
We put stents. I think what is most important is to use stents and also pressure dressing for 48 hours. So closure, tight closure, stent, and pressure on the gland for 48 hours. This changed the. I think it changed all the treatment of salivary gland because we use the same treatment for.
Right.
I didn't have time, but we have traumatic patient with transection of the duct that we just did the same procedure.
Thank you. Any last question? No, Professor Nahlieli, thank you very much for your considerable experience and for sharing it with us.